Hello, everyone, and welcome to today's webinar, Diabetes, the Silent Killer. Why is it the silent killer? Well, our host is going to explain more about why we call it that, but I'll give you a hint. It gets in there and starts creeping along and doing damage, and before you know it, you're in trouble. That's why it's called the silent killer. At the very start, you may not even know you have it. The symptoms may seem more of a nuisance than a real danger or threat. So stay with us and find out why it's called the silent killer. Let me tell you a little bit about our host today. It's going to be Dr. Patrick Carter. Dr. Carter, as you probably already know, is head of our Department of Family Medicine. He's a board-certified doctor himself, of course, specializing in family medicine, but he's also in charge of our quality control and just does a lot of wonderful things. I know personally we couldn't get along without him here at the lakes or anyplace else. Just kind of a great guy. You can read all his qualifications right there, so I'm not going to belabor them, but it is worth mentioning that Dr. Carter has been named time and time again as one of the super doctors of here in Texas, named by Texas Monthly Magazine. And Dr. Carter's also, of course, been nationally recognized by the NCQA for excellence in diabetes care. So now, Diabetes, the Silent Killer with Dr. Patrick Carter. And before I turn the mic over, I want to encourage all our listeners to please type in your questions as you think about them. Don't wait till the end. You may not get another prompt, but if you have a question, go ahead, type it in. Dr. Carter will see it, and he'll take some time and answer them as they come in. And now, Dr. Patrick Carter.
Thank you, John. I'm hoping everybody can see the screen okay. We're having some funny looking things coming up at our webinar screen here. What John said is correct. We're having a lot more patients coming with diabetes. I looked at my practice not too long ago, and over a third of my patients have diabetes, which frankly is a whole lot more than when I started in practice about 25 years ago. And I think most physicians are seeing this as our population ages, particularly as many of us get more overweight and obese. The numbers of diabetics are increasing significantly. And oddly enough, again, thinking back to when I started practice back in the mid-'80s, we really have a lot better medications available now to help control diabetes. So really, if you have diabetes, the good news is that we can control a lot better than we used to be able to. The trick is really getting folks to take their medicine and also getting folks that may have diabetes and not know it to come in and get checked for it. The Center for Disease Control recently came out with a report that said possibly up to a third of Americans could have diabetes by the year 2050. So this really is a growing problem, and certainly those of us in the healthcare field see a lot of it. So let's talk about what is diabetes. Most people realize that diabetes has to do with the sugar, and most everybody knows that when you have diabetes, the problem is that your blood sugar goes too high. What a lot of people don't realize is why that happens, and really the disease of diabetes is an inability to control and utilize the sugar that you take in by mouth. So when we eat food, even if it's not considered a sugary food, a fair amount of it does get transformed into a simple sugar called glucose in the body. And that glucose goes into the bloodstream where it sits until it goes into the cells. And actually your body does need sugar to run. If we had no sugar in our body, we would die. But the problem is that you need to have that sugar go from the bloodstream, get into the cells that need it, and basically not have it pile up so high in the bloodstream that it starts causing the problems related to diabetes. So how does the sugar get from the blood into the tissue? It's by the action of insulin, and most of us understand that insulin is one of the medicines that diabetics might take. In the old days, all diabetics had to take insulin. Now, only a very few wind up on insulin, but it's an injection that you give yourself. But for those without diabetes, insulin is produced by the pancreas, and that's the hormone that's needed to enable that sugar in your bloodstream to get into the cells where it should work properly. And the problem is if the sugar cannot enter the cells, it gets stuck in the bloodstream, and that's where it starts causing the problems related to diabetes. So understanding that diabetes has to do with increased blood sugar, well, what causes it? There's actually two different ways that, main ways that the sugar winds up being too high. One is from just not having enough insulin to begin with, and these are the folks that we now call type 1 diabetics. We used to call them juvenile onset, and these are typically a disease that will start in childhood, excuse me, and this is where the cells in the pancreas that produce insulin get destroyed. And what happens with that is that your body rapidly loses the ability to make insulin, and if you don't have insulin, you will not live, so you have to give yourself insulin. So people with type 1 diabetes or juvenile onset diabetes have to take insulin every day. And they can give themselves shots, or there are now insulin pumps that it delivers a kind of a more smooth dose of insulin throughout the day. They're looking at ways to try to transplant pancreas cells, those sort of things. That's, for the most part, that's still investigational, although some people have had pancreas transplants, typically those that are also getting a kidney transplant at the same time. So type 1 is the pure insulin deficiency. You have to have insulin to survive that. About 10% of diabetics have type 1 diabetes. The biggest increase in diabetics lately, though, is what we call type 2, which are folks that actually do produce insulin, but the problem is their body doesn't respond to it. They are resistant to the effects of insulin. And that's a lot of what I'm going to talk about today, and that's most of the patients that I see in my practice. And these are your more common diabetics, older adults, and that get this, often associated with obesity and being overweight. And then there are some that are sort of halfway in between. Usually they're type 2 diabetics who over time have lost the ability to secrete insulin, and they not only do they need oral medicines, but they also need insulin, and in a triumph of scientific terminology, often we call those type 1.5 diabetics. So there's that too. All right, how do you know if you have it? Well, unfortunately, diabetes is like many other chronic diseases that we spend a lot of time treating today, like high blood pressure and high cholesterol. There actually are no symptoms often early on in the course of it. So if you have diabetes, your blood sugar is mildly elevated, most of the time you feel fine. You don't notice any symptoms. And those folks are usually diagnosed by coming into the doctor and being tested for diabetes. Normally the test is a screening fasting blood sugar, which can be done with a little finger stick, either in the office, or if your workplace sponsors health fairs, or your church or school or something like that, often a screening blood sugar is one of the things that's tested. And so if you're not having any symptoms, but your doctor says, hey, your blood sugar's high, what he or she is looking at is what your fasting blood sugar is. And if your fasting blood sugar is less than 100, you're considered to be normal. If your fasting sugar is between 100 and 125, it's now called prediabetes. Not diabetes, but you're on the road to it. And anything greater than 126, if it's repeatedly that high, is considered to be diabetes. And actually, that's another change from when I first started in practice. It used to be that you had to have a sugar of over 140 at least a couple times, fasting blood sugar over 140 to be called a diabetic. Now that's been redefined down to where if it's over 126 more than once, you're considered to be diabetic. So, so that's another reason why the incidence of diabetics is increasing. Now, who should be tested? Not necessarily everyone, but people with risk factors for diabetes should typically be tested every few years. And risk factors include being overweight. If you have high blood pressure or high cholesterol, those are risk factors. If you have a positive family history, if your mom or dad, sister or brother, grandmother had diabetes, you would be at increased risk and should be tested periodically. It doesn't necessarily have to be every year, but at least every couple of years you should be checked. Obviously, people that have symptoms can be checked too, and the symptoms that you wind up with, if you have diabetes and you don't know it, and the sugar eventually gets up to the point where you start having symptoms, well, these are the symptoms you're going to have. And these are the classic symptoms that type 1 diabetics get. Typically when a child, say an 8 or 9 or 10-year-old gets type 1 diabetes, normally they feel fine until they don't feel fine. And when they don't feel fine, they start having increased urination, increased thirst, They start eating a lot more, and yet they might be losing weight. They also feel tired and lousy and might have blurry vision. So the increased urination is usually quite prominent, and they'll often describe, well, I'm up all night urinating, and I'm up all night drinking water, but I'm still thirsty, and those are sort of classic symptoms. With type 2 diabetics, the most common type today, and these are in adults, usually it's quite late in the game before your sugar gets that high. Usually blood sugars have to be up in the well over 300, often 400 or 500 before you get a significant amount of these symptoms. So as you can imagine, people can bum along with blood sugars that are high, 150, 160, 200, 250 for years, causing damage, and yet they'll never know it. So that's why it's important to get checked periodically for it. So the type 1 diabetes, as I mentioned earlier, about 10% of all diabetics are type 1s. We used to call this juvenile onset. It comes from not being able to make insulin, and it's actually caused by an autoimmune destruction of the cells that produce insulin. So this is one of these diseases where your own antibodies actually attack the cells that produce insulin, and it would treat that with insulin shots or a pump. And again, research is underway now to see whether we can do something about the immune phenomenon, try to keep your body from attacking its own cells, or whether it's possible to transplant healthy pancreatic cells in so that people don't have to take insulin. But those are still under investigation. Type 2 diabetes, what I see in the office mostly, about 90% of all diabetics are type 2. We used to call this adult onset. Now we're seeing more children with type 2 diabetes, and typically that's related to the trouble with obesity. Now we see a lot of children coming in that are quite a bit more overweight than they used to be, and they can develop type 2 diabetes as well. And this is mostly due to insulin resistance. These folks still produce insulin, but their body, particularly the fat cells, just don't respond to it. So remember when I talked about the insulin helps the blood sugar get into the cells? Well, type 2 diabetics, the insulin just doesn't work as well because the body is resistant to it. Obesity is a big risk factor for it. People with family history of type 2 diabetes are more likely to get it. And there's also racial, ethnic predisposition. So African Americans, Hispanics, Native Americans, and Asian Pacific Islanders are at increased risk of developing type 2 diabetes. As I mentioned, we got a lot better medicines now to treat this with than we used to. So most of the time, almost always, someone with type 2 diabetes and type 1 for that matter can be controlled. It's just a matter of doing what your doctor tells you to, taking the medicines, and adjusting your lifestyle. Weight loss for type 2 diabetics is first and foremost the treatment of choice. In fact, the reason we are talking about pre-diabetes now is because if you can catch people in that sort of borderline phase before they become diabetic, start working on losing weight, often that blood sugar will return back to normal, and that's much better than gaining that extra 10 pounds and becoming a diabetic. So diet and exercise are very important. We have several oral medications that can work both on reducing the amount of resistance that your body has to insulin. We also have medications. These are oral medicines, not shots, that can increase the insulin secretion for our patients that can still make insulin. There are also some other medicines not used quite as much but help to reduce the absorption of sugars. And so those are medicines that can be taken sometime along with meals to reduce the amount of sugar that your body absorbs. So one thing I want to point out is the weight loss really is important, and a lot of folks get really hung up about, well, I can't eat sweets. I'm a diabetic, so I cannot eat sweets. And that's in general true. It's not a good idea to eat sweets, but really what's more important is the amount that you weigh. And so this is probably not a good thing to tell people, but my feeling is that if you went on the Oreo cookie diet and all you ate were Oreo cookies, but you were able to lose weight on it, you'd probably be better off than if you were on a fruit and vegetable diet and gained weight. So as silly as that sounds, sweets are something hopefully to stay away from, but more important is maintaining or losing body weight. So if you're diabetic, you don't need to get extremely hung up on sweets, but you really do need to watch your weight. And if you can manage to lose weight, get down into the normal weight range, often that insulin resistance will resolve. So that's what I nag my patients about more than anything, is just, what's your weight? Have you lost any? They get sick of it, but I tell them that's my job to tell them that stuff. So finally, insulin. In type 2 diabetics, people with the adult onset diabetes that are insulin resistant, usually overweight, eventually the oral medications don't work. If you're not able to lose weight and you continue to gain weight, we can maintain you on oral medicines for a long time, but most people will wind up needing insulin. Now, the problem with taking insulin when you're a type 2 diabetic is that you can sometimes, I call it a death spiral, that's probably too dramatic, but insulin itself tends to increase your appetite and make you gain weight. So we wind up in the problem of someone who's already overweight. The oral medications don't work, so we're forced to put them on insulin. The result is, though, that their appetite goes up and they gain more weight, and then they need more insulin. So you get into this cycle where the more weight gain, the more insulin you need, the more insulin you get, the more weight you gain. So that's why we like to attack this early, mostly with weight loss, diet, exercise, be able to either treat you without medications at all or at least keep you on the oral medications. As I mentioned earlier, diabetes is one of several chronic diseases that have been increasing, including high blood pressure, high cholesterol, and those, again, are related often to the same things that bring on diabetes, which is being overweight, not exercising. And so, and with all those diseases, all these chronic diseases, to tell you the truth, the hardest part of treating them is not figuring out what medication to use. It's getting folks to take their medications. So, and I mean, I think I understand why. It's not too surprising. Typically, when I diagnose someone with high blood pressure or diabetes, they don't have any symptoms. You know, doc, I feel fine. And then I say, well, you know, your blood pressure's too high, or your cholesterol's too high, or look, your blood sugar's high, you have diabetes. Since they feel fine to begin with, obviously nothing I'm going to do is going to make them feel any better because they already feel good. And often what I'm telling them to do is what none of us want to do, which is make unpleasant lifestyle changes, particularly go on a diet and lose weight or go out and exercise 30 minutes a day. If often I'm going to try to put you on medications, because you feel fine to begin with, those medicines aren't going to make you feel any better. In fact, sometimes they do have side effects to them. Also, they cost money. They're inconvenient. You know, I left my medicine at home. I'm at work. I can't take it. I went on vacation and I forgot to take it with me. Those sort of things. So it's just an annoyance. And what I'm usually trying to do is, over time, getting folks to take their medicines. What I'm really trying to tell them is that, listen, I know you feel good now, but trust me, if you don't treat this now, that you'll start getting complications in a few years, and by then it's going to be too late. So it's a matter of telling a 30-year-old person who feels fine that, listen, if you don't take this, by the time you're 45, you might have a heart attack, and by the time you're 55, you might need dialysis, and you know, you might be dead at 60 rather than 80. And people certainly understand when I tell them that, but it's hard to bring it home enough to make them want to take medicines every day. So one of the biggest problems with controlling these diseases is getting folks to actually take the medicines and do the lifestyle changes that are needed. And what are the consequences of type 2 diabetes, and actually type 1 diabetes as well? Really, when you get down to it, that high blood sugar in the arteries, what it causes over time is clogging up of arteries. And arteries are the blood vessels that you know, bring the blood to your heart and your brain and your kidneys and your eyes and all the organs that we need. And so you can just, you don't have to be a rocket scientist to figure out, well, if these arteries get clogged up, something bad's going to happen. And sure enough, long-term type 2 diabetes, especially that is not controlled well, will definitely significantly increase your risk of a heart attack. What a heart attack is when an artery that goes to the heart muscle itself gets blocked. Stroke is when an artery that goes to the brain gets blocked. Kidney failure results from blockage of the tiny arteries that go into the kidneys, into the tissue of the kidneys themselves. Blindness, which can result from diabetes, is caused by blockage of the tiny blood vessels that go into the retina, the part of the eye that senses light. You've heard of folks with diabetes who wind up needing an amputation. The reason is because their arteries to the legs typically or the feet get blocked. Blindness can happen, as I mentioned. Nerve damage, same thing. Arteries to the nerves get blocked off and your nerves don't work. It can cause chronic loss of sensation, numbness, tingling, and also pain. Pregnancy is very problematic when you have diabetes, and keeping the blood sugar under control is not only tough to do during pregnancy, but it's vital to ensure the health of both the mother and the child. And also people with diabetes, their immune system doesn't work very well, so they're more prone to getting infections. The sugar in the blood actually is, bacteria loves that stuff, so do funguses and other things that cause infections. So if you're running around with high blood sugar, you're at much higher risk of infections. So there's plenty of reasons to diagnose diabetes if you have it, and to control it if you have it, even if you feel well. I'm going to throw a bunch of numbers at you. This slide's actually a couple years old, and now they're saying 24 million Americans have diabetes, and probably 16 to 20 million have prediabetes. Prevalence of diabetes has increased significantly since during the 1990s. 800,000 cases new last year, and about a third of diabetics don't know that they have it. So this is the public health issue that we deal with, trying to find people with diabetes and get them to be treated. Big numbers, money. Diabetes costs about $32 billion worth of worker productivity every year. Adults with diabetes are out sick a lot more than adults without diabetes, to the tune of over 8 days per year versus less than 2 days per year. And this is so this disease is actually very important to employers and the economy as a whole. The amount of productivity that's lost and wages lost due to diabetes is just phenomenal. And I'm not sure this even counts the people that don't have a job anymore because they have diabetes, because they become disabled, or for whatever reason they're not able to hold a job due to their illness. More numbers. Yearly medical expense, if you have diabetes, is over $10,000 a year, compared to someone without diabetes, where the average yearly medical expense is less than $3,000. Total cost of the diabetes in the U.S., almost $100 billion. So, what do we do about this? Well, preventing diabetes, obviously, with most things in medicine, we feel it's better to prevent things than to have to treat them after they've developed. And diabetes is a very preventable disease for most of us, particularly the type 2 diabetics. It is quite preventable. So, in high-risk patients who are obese, maybe already have a diagnosis of prediabetes, diet and exercise. And I do tell folks, there's plenty of people running around quite obese, maybe 100 pounds overweight, and to think of losing 100 pounds, most people would just say there's just no way, why even bother? But the fact is, you do not have to lose 50 pounds or 100 pounds. 10 pounds can make a difference. Probably 5 pounds can make a difference for a lot of people. So just getting a reachable goal, sticking to it, losing 10 pounds can make quite a bit of difference with that. Diet and exercise resulting in only 5 to 7% reduction in weight results in an almost 60% decrease in new cases of diabetes. So all I do is nag people all day long. So lose weight, take your medicine, check your blood sugar, keep your doctor's appointments. And while management of diabetes, if you put it in those terms, well, that looks pretty simple. The problem is, as I mentioned before, that people just don't do it. And there's 1,000 reasons not to take your medicine, 1,000 reasons not to lose weight, not to exercise, and certainly more than that to not keep your doctor's appointments. But folks that do all these things, we're able to keep them under pretty good control, and their lifespan, is pretty normal. They are able to avoid all those bad things that can happen, as I mentioned before, and they do quite well. The trouble is just getting folks to come in and do it. In order to help patients with learning about their diabetes and reminding them that it's time to have these things done, many organizations have formed diabetes management programs. Here at Kelsey-Seybold Clinic, we have a diabetes disease management program, and there are multiple people that are involved in this. Our nurse educators are nurses that have special training in the disease of diabetes. They spend a lot of time with our patients describing the disease itself, how to take care of it, what are the consequences of not taking care of it. Almost every patient that goes sees a diabetes educator, when they come back, they're in better control. So obviously they're saying something I'm not, or they're saying it in a better way. But it's very helpful for us to have the nurse educators to teach our folks about diabetes. Dietitians deal largely with the diet, which frankly is 90% of caring for these folks. Getting folks to follow the correct diet and lose the weight down to a more reasonable weight, really that by itself will do most of what I try to do with medication. So dietitians are also a very important part of that team. We have clinical practice guidelines for our doctors. Our electronic medical record kind of reminds us when we see folks in the clinic. One thing I always talk about is for my diabetic patients that don't want to come in and see me, they're ones that would rather talk about anything than their diabetes. Well, the time when I can get them is when they actually come in for something else. So if you come in and see me because you banged your elbow or because you have a cold or because your toe hurts and you have diabetes, I will take that opportunity to nag you, and most of our doctors try to do that as well. So we have automatic reminders for our physicians that, hey, you're due for this blood test, or we need to check you for kidney damage, those sort of things. We do systematic monitoring of diabetic control. So in our electronic medical record, we have a way to generate lists of all of our patients with diabetes, and we can also tell when these patients are overdue for whatever, for a refill of medication, or when they're due for a doctor's visit or blood work. And we have a team of nurses that will start off gently by sending you a letter saying, hey, it's time for you to come in and have your blood work done to see your doctor, and if that doesn't work, we call you up and nag you by phone. So I call that professional nagging, but really it does help our patients a lot, I think, and most of the time they do appreciate it. They realize they're supposed to come in, but it doesn't hurt to get a phone call from us if you're late. So those are the ways that we're kind of approaching diabetes these days, certainly here at Kelsey-Seybold Clinic. We also have several resources available for you. If you have diabetes, or you have a loved one who has diabetes and you want to find out more about it, you can use our Kelsey Research Foundation Health Information Center website, or if you come into our clinics that have these centers, the nurse who staffs it will help you get information about diabetes. Our Kelsey-Seybold website at www.kelsey-seybold.com also has information about diabetes. And if you just Google diabetes, you'll get thousands of hits on various organizations. The American Diabetes Association is obviously a very good, credible source of information as well, and that's at www.diabetes.org. So with that, I'm going to wrap up my comments, and I will see if we have any questions. Questions are coming up. First one is, what's causing this increase in children having type 2 diabetes? The biggest reason for that is obesity. I'm sure if you had 10 people, they'd give you 10 reasons why more kids are obese, but certainly you can't read the paper or watch TV without somebody complaining about increased snack foods, increased fat, increased calories in fast foods. Everybody loves going to a fast food restaurant, but over time that does get you. So obesity is the biggest thing. There are also some demographic changes in America. So the populations, the ethnic populations that are high in diabetes are increasing. So African Americans, Hispanics, as our population changes, you're going to see more diabetes just because of demographic changes as well. Is gestational diabetes a precursor to regular diabetes? What gestational diabetes is the diabetes that you get when you're pregnant. So many women do not have diabetes. They get pregnant. We start checking blood sugar, and lo and behold, their sugar starts going up, and that's called gestational diabetes. And the answer is yes. That is if you have diabetes during pregnancy, even if it apparently goes away after you deliver, you're still at increased risk of having diabetes. So that's an early warning sign that if you've gained weight during pregnancy, try to lose it, because that will help to keep that away. So the answer to that is yes. What's the single most important lifestyle modification for avoiding onset of type 2 diabetes? Well, first three, I guess, would be diet, diet, diet. So obesity, avoiding being overweight, avoiding being obese. And people say, well, how do I know when I'm overweight? And the rule of thumb we usually use is that one thing I ask folks is, what did you weigh when you were in high school? That's probably your ideal body weight. And I know I weigh more than I did. Most everybody does. But that's an idea. It's your adult height usually by the time you graduate from high school. And if you were 5'10" and you weighed 160 pounds, and now you're 50 years old, by golly, you're still 5'10", but now you weigh 260. You've gained too much weight. A rule of thumb also for women: 100 pounds for your first 5 feet of height, and 5 pounds for every inch over that. So if you're 5'8", your ideal body weight would be around 140 pounds. For men, it's 106 pounds for the first 5 feet, and then 6 pounds for every inch over that. So you can do the math, but most people realize when they're a little bit overweight. So lifestyle modification would be diet. Second most important would be exercise. So exercise, it's hard to lose weight just by exercising, and I will say that for all my patients come in and say, well, doctor, I hate dieting, I'm not going to do it, but I'm going to exercise my way to good health. It is very tough to lose a significant amount of weight with exercise alone without changing your diet. You can increase your cardiovascular fitness, and exercise is always good, but don't expect to lose 20 pounds just by exercise. You really have to diet. Can eating too much sugar actually cause type 2 diabetes, or is that an old wives' tale? Well, to some extent that's an old wives' tale, unless you gain weight by eating too much sugar. So the problem with eating sugary stuff is that will cause a temporary bump in your blood sugar. So if I eat say, trying to think of something not terribly sweet. Maybe I ate some mashed potatoes. That my sugar will go up somewhat with that over the course of a couple hours. Then it comes back down. If I ate the same amount of calories in the form of a Milky Way bar or something like that, the sugar would go up quite a bit quicker and higher. It would eventually come down, but that peak of blood sugar is harmful as well. So eating too much sugar won't really cause it. It's not good to eat too much sugar, and especially if you eat so much that you're gaining weight, that actually can cause it eventually. Can diabetes really lead to blindness? Absolutely. We try to control blood sugar as best we can, and keeping it down in the normal range can certainly delay or prevent blindness, but there are plenty of people with significant visual decreases and blindness that's due to diabetes still today. What does it mean to be pre-diabetic? That's a term that just refers to your fasting blood sugar being higher than normal. Most people, if you don't have diabetes and you're otherwise healthy, most people's fasting blood sugar, their blood sugar first thing in the morning, is usually around 80, 85, something like that, 90 maybe. So if your fasting sugar is over 100, that really is higher than probably 95% of everybody else. And if your sugar is between 100 and 125, even though that, if it never got any worse, if that's all you ever had was that mild increase in blood sugar, you probably wouldn't be at great risk of all these terrible things that can happen from diabetes. But most people don't stay there. The problem is if your fasting sugar is 110 this year, it's going to be 120 next year, it's going to be 150 the year after that. And the reason is that people do tend to gain weight. Just getting older to some extent will cause you to not be able to metabolize sugar as well. So it is important. If somebody tells you you're pre-diabetic, start dieting, lose the weight, go ahead and start exercising. Try to keep yourself from becoming a real diabetic. Can the increase in type 2 diabetes be attributed to an increase in obesity? To a large extent, yes. Again, as I mentioned before, some demographic changes, family history and other things can also lead you to have type 2 diabetes, but far and away the most important risk factor, certainly the one that's the modifiable risk factor. You can't change your parents, but you certainly can change your diet. So what's the most important thing for most people with type 2 diabetes to work on is diet. And yes, increase in obesity is almost without fail going to cause an increase in type 2 diabetes. What's the normal ranges for postprandial blood sugar? Postprandial means after you've eaten something. And Usually 2 hours after a meal, your sugar should be less than 200. Most people's will be down below 150. So if my fasting blood sugar is 80 and I eat a reasonably good breakfast, 2 hours later, probably my blood sugar is going to be down below 100. Someone with diabetes, it will typically be up above 200. Using lab values, at what point do you decide to put a type 2 patient on medication? Good question. What we use a lot is a lab test called the hemoglobin A1C. And what that does is it shows us what your average blood sugar has been over the past 3 months. It's a very handy thing to have, and that's a big improvement in diabetes care or monitoring since I started off in practice. We started off, when I first was in practice, we'd have patients check their urine to see if there was any sugar in it. Well, your urine didn't get sugar into it till your blood sugar was quite a bit high, and it wasn't a very good way to tell how your diabetes was being controlled. Later on, we got the ability to check blood sugars at home, which is nice, and that tells you what your sugar is today, this minute, but it doesn't really give you an idea of what your average blood sugar has been. So this lab test called the hemoglobin A1C, which we'll typically do about every 3 months, that shows us what your average blood sugar is. And 7 is the magic number on hemoglobin A1C, and a hemoglobin A1C of 7 corresponds to an average blood sugar probably in about the 130 range. So if you check your blood sugars every day and your fasting blood sugar is up above 130, say, probably your hemoglobin A1C is going to be over 7, and that's at the point where I would say you need to be on medication for that. So long answer to that, but fasting blood sugar is much above 120, 130 on the average. If we give you a shot on diet first, but if you don't lose the weight and bring it down, we'll want to put you on medications for that. If you're diagnosed with insulin resistance and decide not to take metformin, how much damage will you be doing to yourself? Good question. Metformin is, in my mind, one of the revolutionary medications, and that is one medication that has really helped me and my patients, I think, bring blood sugar down in type 2 diabetes. Metformin's been around for a long time, although it only became available in the United States back in the 90s. And that's the most common first medication we will use for people with type 2 diabetes who are overweight. And as the questioner asked, what it does is it reduces insulin resistance. It helps the insulin in your body work better. If you are diagnosed with insulin resistance, type 2 diabetes, and you either decide not to take metformin or some people can't take it for various reasons, there are other ways we can work on it. So metformin is not the only medicine available. So most commonly we will be able to control your blood sugar with other medications. The most common other medication that's used that deals with insulin resistance is pioglitazone, or it's called Actos. So that's another medicine we can use. We also use medicines to increase the amount of insulin that your body produces, and with those two we can often get people under control. The damage that you do to yourself has more to do with your average blood sugar than what particular medication you're taking. So if we can keep your blood sugar where it needs to be without metformin, you're not really damaging yourself. If you're somebody that we've tried everything else and you either don't want to take metformin or you can't, then that is more of a problem. But there are plenty of medications we use. As I mentioned earlier, the problem is getting folks to take them. So the best thing you can do if you're a diabetic is, try to see your doctor. Let him or her, talk to you or nag you like I do. Try to do as best you can to control the weight and take the medications. If a medication doesn't work or it's too expensive or it causes side effects, don't just stop it. Just go back to your doctor and let him or her know what's going on. And usually we can figure out something that will get that sugar under control. The last thing I will say is that if you have diabetes, make sure that your family members are being checked for it, because it is something that does run in families, and you'd hate to have your brother or sister or son or daughter or somebody like that running around with diabetes and not knowing it. So please try to make sure that they're being checked. And with that, I think we're out of questions, and I've told you everything I know, so I think we'll wrap it up there. Thank you very much for listening in.
All Right, everyone. Thank you so much for joining us today. Make sure to join us for our next webinar, which wellness experts Brian Weger and James DeMoss will present, "'Tis the Season for Healthy Eating," and that's on a Wednesday, December 1st. Again, thank you for joining us, and a special thank you to Dr. Carter. Goodbye.